Hi, everyone. I'm Rachel Beekman. I'm a neurointensivist at Yale New Haven Hospital in New Haven, Connecticut. And I am so pleased to be here today with my mentor of nearly 8 years and friend, Dr. Emily Gilmore. We're going to discuss the risk of COVID-19 infection and of severe complications among people with epilepsy.
Thanks, Rach. I really appreciate you agreeing to do this with me. And it's been an honor to watch you grow and develop, not only as a resident and a fellow, but now as junior faculty, and to have the opportunity to actually collaborate on something like this together. So thanks again for agreeing to participate. So as Rachel said, this is the study that we're going to be discussing. And I think just to, like many studies that have come out in the last few years, they've capitalized on COVID-19's effect on different patient populations. And it's lent itself to a tremendous opportunity to explore associations amongst different diseases. And so in this particular study, we're going to be looking at whether epilepsy has a specific risk related to COVID-19. And so they're going to investigate whether patients with epilepsy were more susceptible to COVID-19 and whether those patients had a higher risk of severe complications in that setting. So just to give a little bit of background about epilepsy significance in general, right? Epilepsy is a very common disease that affects 70 million people worldwide. It is a chronic medical condition like other chronic medical conditions, including hypertension, diabetes, and heart disease. And interestingly, its mortality is higher than that of the general population. Epilepsy in general, its related mortality remains pretty underappreciated and in many ways is deemed or thought to be sort of a public health emergency. And in general, public health interventions are inadequate. Oftentimes, patients with epilepsy require quite a bit of resources to maintain their health. And not only do they have a higher risk of developing things like stroke, ischemic heart disease, and cancer, some of those risks actually may be related to their underlying anti-seizure medications. There's been supported hypotheses that epilepsy medications actually increase atherosclerosis. In addition, epilepsy is associated with sometimes not even causative of these morbidities, but also associated with them. They tend to coexist. And so, for instance, compared to the general population, people with epilepsy have twice the risk of psychiatric disease and a sevenfold risk of cerebrovascular disease. And so some of these studies here have just kind of shown the association of epilepsy-related mortality over time. And I think it's stark and surprising, and something that I honestly would say, I don't know about you, Rach, but like I honestly hadn't thought that much about it, but we see quite a few patients with refractory epilepsy in our ICU, and it made me really pause and think about how should I be thinking about these patients differently. So I look forward to reading this study to be able to integrate that into my clinical practice. And so I think in general, so not only is epilepsy associated with some of the things I mentioned, and that relationship is somewhat bidirectional, it turns out there's actually been research looking at causes of death in patients with epilepsy. And in general, pneumonia is a common cause of premature mortality in persons with epilepsy. And that's relevant in particular to this study. And so that's why we thought that this was helpful background information. And this relationship between infection and epilepsy may in fact be bidirectional. And so in these two studies using administrative claim data, sepsis survivors were at significantly higher risks of epilepsy. These findings indicate that sepsis may be under-recognized risk factor for epilepsy. And there's been some ongoing research, particularly in COVID-19, is a virus that targets the angiotensin-converting enzyme 2 receptor, which is not only found in the respiratory tract, but actually in the cells of multiple organs, including the brain. And so there might be some correlationship of lung disease and brain disease in COVID-19. And finally, just to provide some further background information in general, the overall socioeconomic burden of epilepsy is significant, and patients with epilepsy face discrimination and social stigma. And during pandemics, particularly we saw this in COVID, patients had more challenges with actually accessing the care and also getting medications that they might need to treat their epilepsy. So in general, I think this is a really interesting question, and this background provides a framework for which we're going to explore the study. And so I'll turn it over to Rachel, who's going to talk a little bit about COVID significance in general.
Thanks so much, Emily. Yeah. So as we've seen in, now almost 3 years, SARS-CoV-2 is the virus that causes COVID-19, and it's now caused over 1 million deaths in the US alone. And the prognosis of patients, while overall is not bad, there's a significant proportion of patients who experience critical complications. And in terms of trying to figure out what is behind that, we know that there's significant strain on hospital resources during the pandemic, and especially early in the pandemic, especially with the shift of resources to the inpatient side versus out of hospital, and a fear of going out into the medical community if you had an underlying health condition. This leaves patients with chronic diseases, including epilepsy, either missing preventative care visits or missing routine follow-up visits. And it also may lead, as you said before, to decrease access to their medications, which could lead to poor seizure control. We don't really know the impact of congregate settings on infectious risk. There were some concerns really early in the pandemic that COVID-19 was going through nursing homes. And while we don't really fully know the epilepsy population in this cohort, we'll talk a little bit more about that going forward. But patients who do live in a short-term rehab or a skilled nursing facility are potentially at increased risk of exposure to this virus. As we discussed a little above, epilepsy is really not one disease. It's a heterogeneous disease, and it can be due to anything from congenital syndromes like Landau-Kleffner, which we'll talk about in a second, was included in this cohort. But it actually could be also secondary to medical disease, like what we see in localization-related epilepsy after strokes. And so it is known that certain medical conditions are associated with worse outcome with COVID. But what we need to kind of sort through in this paper is if epilepsy is one of those conditions that increases both your risk of developing COVID-19, but also the risk of having a poor outcome with COVID-19. There are some emerging data that the evidence of COVID-19 in patients with epilepsy is higher, although it is limited to small sample sizes.
Great. Well, so why don't we actually dig into the study a bit more and talk a little bit about the population and who they studied, right? So this was a retrospective observational study using a nationwide COVID-19 data set in South Korea. It included participants who underwent at least one severe acute respiratory syndrome coronavirus 2 real-time reverse transcriptase PCR test between January 2020 and June 2020. So very early on in the pandemic, and in only over a 6-month period, and presumptively because they thought that would be reflective and generalizable, but we'll get into some of the limitations as to why that may or may not be. Diagnoses at each of their hospitals were recorded using ICD-10 codes. So the study was possible because they have a national healthcare system which tracks their whole patient population. And so they were able to then use that to then release a nationwide data set for all patients who underwent COVID-19 testing for academic research, and then to do post-hoc analyses of that cohort. So for this particular study, it included a little over 212,000 patients. And as you can see here, it broke it down into those with and without epilepsy who actually had testing done. So the cohort was about 208,700 without epilepsy and 3,900 with epilepsy. And then they used a match cohort with and without epilepsy, which we'll get into some of the details of. I think it's important to recognize, Rachel mentioned previously the etiology of epilepsy. And I think, using their ICD-10 codes, which are listed there, they included folks who had a diagnostic code of epilepsy or seizure, status epilepticus, Landau-Kleffner, as Rachel mentioned, and convulsion, right? And had an insurance, used that code in an insurance claim that preceded their COVID test, but were also prescribed an anti-seizure, anti-epileptic medication. And so we know that this is a very heterogeneous population of patients diagnosed with epilepsy. These aren't your known refractory epilepsy patients solely, or your known syndromic epilepsy patients. These are patients who could have had a provoked acute symptomatic seizure and been put on an anti-seizure medication, and because of the way that they classified patients, ended up being called epilepsy for the purposes of this study. Okay. I think the other thing just to recognize is that they defined severe complication as a composite of the incidence of mechanical ventilation, again, using claims codes, admission to an ICU using procedural codes, or mortality within 2 months after a positive COVID-19 test diagnosis that was provided by their National Health Service. Right. And so in looking at some of the baseline characteristics, there was really no difference in baseline characteristics in those who underwent testing with or without epilepsy, but there were some differences in those who tested positive, and particularly with regards to age, economic status, and cardiovascular risk factors in malignancy. To balance these differences, they ended up using a 1 to 6 propensity scored matching protocol, in which they then tried to balance those characteristics that were statistically significant. And those particular characteristics were household income, hypertension, and malignancy. And they used a logistic regression analysis to do that. Their primary outcome, and as alluded to earlier, was to assess whether patients with epilepsy had an increased rate of COVID-19 infection, as evidenced by a positive test, and whether they were more frequently died of severe complications of the COVID-19 infection. And again, using the definition of severe complication that we discussed, but it's important to just remind ourselves of it. It was defined as that composite of incidence of mechanical ventilation, admission to an ICU, or death within 2 months after a COVID-19 diagnosis. And those 3 subgroups of patients might actually be quite different, especially when we're talking about epilepsy patients who might aspirate and get intubated because of a seizure, end up having an incidental positive test. And we'll get into some of those details when we talk about both the results and the limitations, but just something to keep in mind as we continue to dissect this study. So Rachel, why don't I turn it over to you to talk about some of the results?
Sounds good. Thanks so much, Emily. So all of the patients in this nationwide Korean cohort between January 1st, 2020 and June 4th, 2020, only 3.6% of patients tested positive for COVID-19 and then were included in the analysis. So that leaves 7,641 patients without epilepsy and 72 patients with epilepsy. And, the test positivity rate is relatively low, but it is also early in the pandemic where testing was maybe not as available as later on in the pandemic. As Emily said, in an effort to control for confounders, the study team used propensity matching design, leaving 432 patients without epilepsy in the matched cohort. In this table here, you can see the baseline characteristics of patients with COVID-19 before and after propensity score matching. And I'm going to focus a little bit on the pink highlighted regions, because what stands out to me is that in the epilepsy cohort, the patients are relatively older. So you have a high proportion of patients that are 60 and above. And they have quite a bit of medical comorbidities, including hypertension, diabetes, stroke, coronary artery disease, and heart failure. And so what stands out to me is that these patients are more likely to be secondary epilepsy patients than patients with congenital syndromes or diseases like Landau-Kleffner. I think that's important when getting into a dissection of the study data itself. So getting a little bit more into the results of the study, in this table here, you can see that the presence of COVID-19 did not differ between patients with epilepsy and patients without epilepsy. And actually, if you look prior to the propensity score matching, although it no longer becomes significant, patients with epilepsy were less likely to have COVID-19. And we know from the prior table that patients with epilepsy had more medical comorbidities. And so while this ends up being non-significant, it does raise the question whether perhaps because these patients were higher medical comorbidities, older patients who self-deem themselves to be a higher risk for severe complications of COVID-19, if they were more cautious and thereby limiting their exposure. In this next table, we see that severe complications of COVID-19 were twice as likely in patients with epilepsy. And although there was no difference in mortality, So some of this impact is probably related to medical comorbidities. You can see that the odds ratio decreases after propensity score matching, but there is a difference that still persists, especially for severe complications, suggesting that it's not just these medical comorbidities that are having an impact on severe complications of COVID-19. But that significance that you see prior to propensity score matching, it does not persist in death. We discussed this a little bit earlier. There's no granular details, so we don't know why these patients needed mechanical ventilation, what the indication for ICU admission was. And so it is not clear from this data whether the worst outcomes are related to either a respiratory decompensation requiring intubation and ICU admission, or in fact, if actually it was a neurologic decompensation, perhaps they had worse seizure control that required ICU admission. You know, I do think it's important that the death rate is not statistically different between these groups. And I do think that suggests that there's possibly a reversible process going on. But we also don't know the impact of withdrawal of life-sustaining therapies and if that affected the mortality rate differently between the groups.
Right. So overall, you know, I think it raises some interesting questions and concerns about what is it that drove the increased complication rate in epilepsy patients versus in what didn't bear out in mortality, right? And so as you alluded to, Rachel, like perhaps some of this is related to the reversibility of it. And knowing what we know now, 3 years into this, and in which we're admitting a lot of patients to ICUs, in which COVID is actually an incidental finding. They test positive, they aspirated because of their seizure, they got intubated because they were still seizing, you know, and needed airway protection, right? Are those two things truly related? And perhaps not. And so I think, you know, the key findings, and what I mean by not related, right, is that the COVID wasn't what caused the pulmonary decline that warranted intubation and an ICU admission, but rather their epilepsy, right? And that we know that those patients are at high risk for aspiration, and that pneumonia in general is a cause of mortality. I think also alludes to the fact that if COVID-19 were really severe in those patients, they would have actually probably died. But because they didn't, perhaps, right, there might be an element of this which was an incidental finding just on a positive test as opposed to true severe disease, right? And I don't know that we'll know the answer based on this study, but it is provocative to kind of think about that. Because I think maybe the authors might have expected that epilepsy, given you know its association with other morbidities and also with increased mortality in general, right, that we would have seen an increased mortality in this patient population. So I think somewhat reassuring, and we'll get into a little bit more in the discussion and in the clinical relevance of how we use this information to take care of patients moving forward. But I think just to highlight the key findings of this study, which were that individuals with epilepsy did not have a greater COVID-19 susceptibility as manifested in the testing that was done, with some of the limitations that you mentioned about the early time frame of the pandemic and the testing availability and perhaps the testing sensitivity. But they did, right, at patients with epilepsy were at higher risk for severe complications, again, with the limitations and the definitions used for this study. So need for mechanical ventilation, admission to an ICU, or death within 2 months of that positive test. As you mentioned, a lot of these patients we don't have the granular data on, so we really don't know the true etiology of their epilepsy and even the severity of their comorbidities or their baseline functional status. And so we assume that although they did propensity score matching to try to level the playing field, it's unclear whether those two groups were balanced in a way in which the null hypothesis was favored, right? So not surprising that these results were seen, in part because we've actually seen this in other cohorts. And this was a study in children with COVID-19 and Down syndrome, which looked at risk factors for hospitalization, in which seizures and epilepsy were statistically significant. You can see by the odds ratio there. However, that was not so much the case for the development of ARDS. And so a very similar finding to the study that we're just reviewing.
Yeah, that's a really good point, Emily. And I think, you know, one of the other things that we're trying to get at is, well, is this something that's associated with any viral illness? Because we know patients with epilepsy are at increased risk for refractory seizures in the setting of sepsis or another type of infection, or is this actually something that's unique to COVID-19? And so while this study is unable to answer that, there have been published studies looking at the incidence of epilepsy over time after COVID versus after flu. And so in this study here, you can see that there is a difference in new onset seizures or epilepsy between influenza and COVID-19. But actually, that's driven mostly by patients who ended up not hospitalized. So patients with non-severe COVID ended up having a higher rate of seizures or epilepsy a few months after their infection, versus patients who were hospitalized with flu or COVID had very similar rates of seizures and epilepsy, suggesting that maybe even in the non-serious COVID patients, that there's something going on that increases your risk of having seizures.
Right. And I think, I showed that in the earlier slides, right, with regards to chicken and egg phenomenology. So, we don't know what happened to these patients before January of 2020. Had some of them had flu-like illnesses or other infections, right, that predispose them to getting COVID-19, they get admitted, and perhaps some of the seizure-related incidence is impacted by that, right? And so we don't really know. We do know, right, from the earlier slide I showed about this association of sepsis and seizures, right, that sepsis increases your risk for developing epilepsy, and epilepsy might increase your risk for hospitalization, right? But not necessarily some of the severe complications of hospitalization and respiratory illness, not only seen in COVID-19, but also in influenza. So I think to close out with just some relevance to clinical practice, right? I mean, I think what you've nicely shown, Rachel, is that, this, whether it's COVID-19 or influenza, right, these results actually might have been the same. That epilepsy patients may be more susceptible to severe disease in general because they have less reserve. But again, it's a little bit hard to sort out in this study, given the way they define severe disease, whether it's truly related to COVID-19 or just how they defined severe disease, right, as being, again, intubated, needing an ICU, and then ultimately the third marker of death within 2 months. The occurrence of status epilepticus requiring ICU admission and intubation may have been increased in patients with epilepsy, in part due to severe inflammatory response syndrome from COVID-19. So it gets at that point about whether it really was severe disease related to COVID-19 or just the severity of their presentation being, the fact that they were in status and needed to be intubated. I think the other thing to think about, especially as we move forward with regards to COVID and its treatment, is that seizures and epilepsy treatment may actually interact with COVID-19 treatment, reducing its efficacy. And so things like Paxlovid, which can be impacted by enzyme inducers, many of which anti-seizure medications are, right? So just something to actually think about when you're treating patients with epilepsy. I think in addition, in a study involving only Korean patients and whom required intubation and ICU level care, no data, as you mentioned, was provided by about withdrawal of life-sustaining therapies. And so we don't know what impact that might have had either culturally or on the overall outcome, but potentially that was balanced out between the two groups. I think it was also challenging to interpret this data in the context of later months in the pandemic, when we went from scarce resources and not knowing much about the disease to later periods of the pandemic. And it would be interesting to look at the first 6 months, which this study really represents, and the last 6 months, and to see whether there are actually any differences between those two time points. But it does raise the question of, because of some of those limitations we've talked about, whether this is really generalizable, not only to other ethnic groups, but the current state of COVID-19 and its impact on our current healthcare system. And then I think finally, because of our shared interest in neurocritical care and our use of EEG monitoring as a tool to understand seizure and seizure control, there was no data on whether EEGs were used, as I mentioned earlier, the etiology of the epilepsy, duration of disease, or even neuroimaging to understand, right, whether these patients, we know that COVID is associated with increased risk of acute stroke and other complications. And so could patients have suffered other complications of COVID that might have contributed to some of the outcomes. So I think in general, really interesting study, provocative in some of the questions that it raises. I think there's more work to do to really tease out some of the granular issues that we dissected today. Overall, I think it doesn't really change our clinical practice, but I do think this study has made me more cognizant of epilepsy as a risk factor for severe disease in general when patients are admitted to the hospital. And I actually enjoyed the opportunity to review it. I don't know, Rachel, if you have any other final thoughts about it or how it might impact your practice moving forward.
Yeah, I completely agree. I think it was a really interesting article to go through. I think it was great to think about all of these components, and specifically the difference between COVID and other infections that patients with epilepsy have, and how that impacts their risk for a poor outcome. I don't think it's going to change our practice overall, but it may actually prompt you in a patient who comes in with COVID-19 to do some more monitoring. You have a less responsive patient. Maybe those patients who are going to the medical ICU for their ARDS should all be on EEG, because maybe they do have a risk factor that we need to look at in more detail. So it might prompt you to look a little further and treat them as a higher risk group.
Totally agree. Well, great. Thank you guys for taking the time to listen today. We hope that you enjoy reading this study as well. And we look forward to anybody who has questions and wants to reach out to us. Our emails are our first.lastname@yale.edu, and we'd be happy to chat offline anytime.